Professor, we cannot hear you.
Oh, I thought it was me.
Oh, can you hear me now?
Yes.
Yes.
Okay, so I was saying, let's start here. So causes, just read them on your own. They're nice to know. The question on this would probably be prevention. So which of the following will be included in the teaching for preventing traumatic brain injuries? So these are your answers. So this paragraph here, along with this paragraph right here. I was saying with regards to helmets and motorcycles, at least with the helmet, of course, that won't give you 100% protection, but at least we don't have to pick up or scrape up pieces of your brain off the asphalt. Okay, at least all your brain tissue is inside the helmet, so you can be buried together. Okay, rather than you're missing parts of your anatomy. This one is included because most of our patients are older adults. Let's go now to our signs and symptoms. They will be divided into three. We have mild, moderate, and severe TBI, which will be on table 45-4. These are some of our common assessments. So we need to recognize the symptoms and then address them right away. So we talked about hypotension and hypoxia earlier as the secondary injuries, so watch out for those. And you should address them right away because they will cause further increases in ICP. And we already agreed earlier that both hypoxia or hypercarbia are potent vasodilators, so they do increase ICP. So mild traumatic brain injury. The difference between the three here is in the how long is the loss of consciousness. So in mild, there may be none, or if there's any, the loss of consciousness here is only up to 30 minutes. Loss of memory can be possible, as well as there will be focal rather than diffuse deficits, meaning the patient will have, let's say, mild memory lapses, for instance, or none. As stated here, so loss of consciousness does not have to occur, and if it's absent, doesn't mean you don't have mild TBI. You still have it. And toward the end of the chapter, we will have, because these people with mild traumatic brain injury are not admitted in the hospital, so they will be discharged with specific instructions on when to bring the patient back to the ER or when to call their doctor. That part is later in the chapter. And something here is about when the symptoms resolve. So usually they're gone by about 72 hours, so a few days. However, some symptoms may last, but these are all part of your concussion. So concussion falls under mild traumatic brain injury. And you've heard in sports, or for those who have undergone concussion protocol after sports injury, either in high school or wherever, it's about 2 weeks, right? Usually, at least in professional sports. In moderate TBI, you now have your loss of consciousness definitely is present, and it is present for 30 minutes to up to 6 hours. And we'll discuss the GCS scoring later. That's 9 to 12. So that's a significant Glasgow coma score already. So that's you lose up to 6 points because the perfect score is 15. We'll discuss it again, like I said, back in chapter 41. So these patients will definitely be admitted for further monitoring, especially for the development of secondary injuries. And then finally severe, look at the GCS score here. So there's no way this patient is conscious, or if they even regain consciousness, right? If they have severe injury. So they have both focal and diffuse damage to the brain here. And definitely the cause of the low score here is because of the severe increases in ICP. So this is already 20 or more millimeters of mercury, which is quite severe. All right, one question I remember on the test is, you have to know which are expected and reportable signs and symptoms after head injury. So for mild traumatic brain injury, these are expected, okay? And you have to be specific. The loss of consciousness, for example, less than 30 minutes. So the patient here has headache, nausea, vomiting. So if these are listed on the options, are these reportable?
No.
No, these are clearly expected physical findings in mild traumatic brain injury. So you have to be specific. Okay, so there is expected to be sensitivity to light and noise, and then slow down, difficulty remembering or concentrating, or loss of memory. These are all expected in mild, right? Along with the sleep disturbances as well as some emotional changes. Priority assessments in any level, whether mild, moderate, or severe, always EBC. And of course, you check for other injuries because trauma doesn't always involve only the head. As stated here, patient may have spinal cord injury as well. So in any case, we assume that both are present. Is that clear? Meaning on top of your brain injury, you also include spinal precautions as well. And we will discuss spinal precautions shortly. These are the Cushing's triad. Well, Cushing's triad will be discussed later, but this is already part of this Cushing's triad. So the patient presents with changed strokes respirations. So this is now part of the Cushing's triad, although you need the other two in order to complete it. But either way, Cushing's triad is not a good sign. All it does is confirm that a patient has increased ICP, but it's actually a late sign and it usually indicates poor prognosis. As I already mentioned earlier, we assume that the patient with brain injury also has spinal cord injury. So you institute this as a precaution. So when you receive the order, what does spinal precautions mean? That means you put the patient on bed rest. They're not allowed to be out of bed. No neck flexion, so the patient will have a rigid neck collar. No thoracic or lumbar flexion, meaning the patient will be flat on bed. If you're going to, if there's an airway problem, then we can do reverse Trendelenburg instead of Trendelenburg. Manual control, if ever let's say we're dressing the patient or whatever we're doing, let's say intubating the patient. So make sure whenever the rigid collar is off, that somebody's holding the head steady. And whenever we have to roll the patient, because we still have to take care of pressure ulcer prevention, we'll always log roll the patient. Or when we're doing Judy, for instance, or putting the patient on a bedpan. Any question on spinal precautions? Very
No.
good. All right, so here's the Cushing's triad. Here they are, hypotension or hypertension, along with, sorry. Okay, here's the Cushing's triad. I was wondering why there was hypotension. It's not hypotension, it's hypertension. You have a wide pulse pressure and bradycardia. So the change strokes respiration will complete the triad, which is, what is change strokes respirations again? How do you describe it? irregular pattern with alternating periods of,
Apnea.
yeah, apnea, plus there's also dyspnea, right? So it's very irregular. That's Cheyne-Stokes respiration. Then along with severe hypertension, and there's a wide, show me a blood pressure, give me an example of a severe hypertension with a wide pulse pressure.
180 over 80.
All right, that's very wide. Yeah, that's a good example. So the normal difference between systolic and diastolic is how much?
40.
All right, usually around 30 and 40. Okay, that's the normal wide pulse pressure. So if it's really wide, then that's already a sign of that's part of the Cushing's triad. This really has something to do with the brainstem herniation. Here's a trivia. So take note of all these, okay? Because on the test question, I will not give this exact statement. So instead of saying, no, there's a change of 2 points, I actually give you the change. So I'll start with, let's say, what was the baseline GCS score, and then what is it now? Then same thing with the Cushing's triad. So I will not say severe hypertension with a wide pulse pressure. I'll give you the patient's vital signs, blood pressure and heart rate. Is that clear? Because that's what you'll really see. I mean, you won't see the findings on the patient's forehead, right? So you walk into your patient's room, you assess the patient, and then you see these. You see really severe hypertension with a wide pulse pressure, and then the heart rate's low, and then you do your GCS scoring, and there's a difference of more than 2. Either we're really concerned about a decrease rather than increase, right? Because you always look at it in a certain perspective. So for instance, if the Glasgow Coma scale, for example, is 12, is that good or bad? Hello?
I think that's okay.
Yeah, isn't it okay?
Well, a patient who is confused has a GCS score of 14, meaning your dementia patients have a score of 14. That's okay. So, maybe you'll appreciate it later when we get to the Glasgow Coma score practice. Okay, but at 12, that's already before. So if it was 14 before,
Professor,
now it's 12.
Professor, sorry, we lost you after 12.
Okay. All right, so I was giving the example of a patient having a Glasgow Coma scale score of 12. So when you say 12, that's already a characteristic of moderate TBI, correct? However, you always want to look at it from a certain perspective. For example, it will be significant if you look at the prior score. So for instance, the patient's GCS score was 14 and now it's 12. Yes, that's a significant change. However, what if it was 10 earlier and then now it's 12? Is that still bad?
No, it's good.
Okay.
Now it's improved.
Okay, so that's what I'm saying about you always look at it from a certain standpoint. Okay, so what was it? What was the change from? Was it better or was it worse? All right, so again, questions on this next exam will be a lot of these actual findings, and then you'll have to make a decision, okay? So always look at applications, so not just these statements here, but your actual findings. And there's never a scenario wherein you're just looking at vital signs. So what did we start with at the beginning? What concept were we discussing before we started with chapter 45?
The one Dr. White.
We were talking about the CPP and the Monroe-Kelly doctrine, remember?
Yes.
Yeah, okay. So whenever you see a blood pressure reading, and then especially if there's an ICP data also on the test question, always calculate automatically for the CPP, whether or not you're asked for that. Is that clear?
Yes.
Okay, so you always, you remember this is a brain injury patient, so, or even also with this stroke patient. So there's never something that, oh, that's just looking at the blood pressure and ICP, yeah, no big deal. But really, you're always watching for and calculating for the CPP. Is the patient's brain receiving enough cerebral blood flow or not? Okay, there's no, what is this? There's no innocent data, okay? So you're always constantly calculating for CPP. This statement right here, where it says most important variable to assess is LOC. Remember earlier when we have brain herniation, which is a sign of really serious ICP increase now, because now your brain is pushed out of the skull. And this is usually the earliest sign, okay, of increased ICP. There will be a change in the level of consciousness. Now, it's just a matter, though, of how big or how small is that change. Okay, so any decrease or change in the LOC, that's usually, again, your first sign or the earliest sign of any, especially a deterioration in your neurologic status. If it's an improvement, okay, all good, but what if it's a deterioration? Okay, and your next action after seeing that, of course, will always be report that change to your doctor. Along with your neurologic assessment is always pupillary reaction. Here's a critical rescue here. Please read that on your own. This paragraph, I have 2 questions on these, specifically with the interpretation. For instance, thank you for reading this, Ms. Turner.
Pinpoint and unresponsive pupils are indicative of brainstem dysfunction at the level of the pons.
Okay, thank you. And what about this highlighted section here, Ms.
You want me to read it?
Oh yeah, go ahead, Ms. Turner, thank you.
Asymmetric uneven pupils, loss of light reaction, or unilateral or bilateral dilated pupils are treated as herniation of the brain from increased ICP until proven differently.
Okay, can you read the rest, please?
Pupils that are fixed, non-reactive, and dilated are a poor prognostic sign. Patients with this problem are sometimes referred to as having blown pupils.
All right, thank you. All right, we have 2 posturings here. This is also in regards to specifically Glasgow Coma Scale scoring as far as motor responses. They are scored a 3 and a 2 respectively. The corticate positioning, which is abnormal flexion, has a score of 3, whereas the cerebret has a score of 2. So therefore, between the 2, the cerebret positioning has a poorer prognosis compared to the corticate. Let's go to chapter 41 to see the picture. Here you go, figure 41-7, page 848. So the abnormal flexion here is the corticate, and this one is the cerebrum. Again, between the two, because this one is scored 3, this one it says score 2, so this one would be worse off compared to this one. All right, along with head injury is skull fractures. We saw this in hypophysectomy, although I did not discuss or test it. The presence of CSF can be detected using this this action right here. We use a gauze, because that's an absorbent material. We use it to dab the drainage in order to detect whether or not it's CSF. And the method, of course, is when blood is found at the center of the ring, and there's a that's why it's called a halo, because you'll have blood in the center and a yellow ring around it. That will indicate that the liquid that you are seeing is CSF and not just regular blood. The reason why, because CSF contains sugar, right? The reason why we don't test it for sugar is because there's blood in there too, and blood is always positive for glucose. So therefore, the more reliable method is to do the halo sign. Any question about this? Meaning, if you see any suspicious drainage coming out from the ear or from the nose, for instance, to see whether or not you have a CSF leak, is to do the halo sign.
And it should be positive for glucose as well, right?
I'm sorry?
It should be positive for glucose.
Like I said, we don't use that because the blood also has glucose. So when you test it, of course, it's going to be positive for glucose because there's blood in it. So to rule that out, that it's really CSF, is to do the halo sign. Does that make sense? Is that clear?
Yes.
Professor, like what? Oh, okay, go ahead. I'm sorry.
Okay, so this is what it's saying here. So a halo sign is most reliable when blood is in the center of the absorbent material, because tears and saliva can also cause a clear ring in some conditions. Is that clear?
Yeah, makes
Meaning what Bassam was saying was we tested for glucose. Well, that won't rule out CSF, because yes, there's glucose in CSF, but there's also glucose in blood. Meaning, especially if the drainage has some blood and yellow combined together with it, so of course it will be positive for sugar as well. So again, the most reliable method is the halo sign.
So for the glucose, it's only useful if the drainage was clear or yellow.
Yes. Yes. But most of the time, it's not always clear though, because there will be some blood together with it.
Yeah.
Yeah, so that's why that makes the halo sign a more reliable method. And other signs of head injury or skull fracture are ecchymosis and also tender areas around the scalp and the raccoon's eyes. Please read the psychosocial assessment on your own. Lab, there's really no, as stated here, that there's no lab test to test for brain injury. Our standard assessment, just like in stroke, is always a CAT scan or an MRI. Let's go to interventions now. This should be quick because we already mentioned some of them earlier without even reaching this part. So before we do drug treatment or surgery, surgery here is second in line before we have to institute our non-pharmacologic and non-surgical measures first. So we just learned about primary and secondary injuries. So after, of course, there's nothing we can do about the primary injury. We're already here. Patients already sustained the head injury, and now they're under your care. Now the crucial part here is monitoring for and preventing secondary injury if at all possible. So let's begin with monitoring the vital signs frequently. Avoid any other conditions that will result in further increases in intracranial pressure, which is a secondary injury. So one of them is the patient's temperature. So regardless if the rise in temperature is because of a fever or because of environmental temperature, what is the effect of fever on ICP?
Increases the ICP.
All right, because it's a high temperature causes vasodilation, therefore it will cause increased blood volume, therefore it will increase ICP. Just like you guys, when you have a high fever, do you have a headache too when you have a high fever?
Yeah.
Yeah, so that's evidence there that your ICP is increasing, and that's why you're having a headache. And what is the effect therefore when you take a ibuprofen? Why does it decrease the headache and the fever? Hello?
Ask it again, Professor, please.
Because
So
it's an
why-
inflammatory. So it's going to cause everything to swell more.
Say again, what did you take for
Because-
headache or the?
Well, if you're saying don't take it for a headache because it's an inflammatory medication, so shouldn't that?
Don't take what?
Ibuprofen.
So you don't take it?
No, I don't take ibuprofen for headache, no.
Why not?
I'm allergic to it.
Oh, okay, all right. So besides Janique, so for the rest of us who take ibuprofen, how does ibuprofen decrease the headache and the fever?
It reduces the inflammation.
Okay, that's one. But what about the pain?
It inhibits prostaglandins.
Okay, it inhibits prostaglandin synthesis, and we know prostaglandin is a vasodilator, right? So by inhibiting it, you cause vasoconstriction, blood volume drops, headache drops, or ICP drops, headache drops. All right, so one of the interventions, if the patient develops hyperthermia, is to induce a therapeutic hypothermia. So this will help decrease, this is one of the measures to decrease ICP by causing vasoconstriction, thereby decreasing blood volume in the brain. without necessarily causing decreased cerebral blood flow. All we're dropping is all we're trying to decrease is the blood volume by preventing vasodilation. We already know about oxygenation. So most of these patients come in with altered levels of consciousness and are therefore intubated because they'll be unable to protect their airway, or simply because they're already unconscious. So they will be intubated. So of course that will help us increase their PaO2 while decreasing the EtCO2 levels, or that's called Untitled CO2 values. We'll discuss that in chapter 32 under mechanical ventilation. So far we've had therapeutic hypothermia and oxygenation, which is accomplished if necessary by intubation and mechanical ventilation. So we have 2 interventions there so far for decreasing and preventing rises in ICP. Another is positioning. So the best evidence here is 30-degree head of the bed elevation, or the highest will be 45 degrees. And of course, no extreme hip flexion or knee flexion or neck flexion. So the head should be midline. We want to make sure there's nothing impeding blood drainage through the jugular veins. So therefore you can't have any neck flexion. Also the hip should not be flexed. That's why our head of the bed elevation should not be more than 45 degrees. If you go 90, then there will be extreme flexion that will increase intrathoracic pressure and therefore will impair venous return from the brain. Plus remember, what is the effect of head elevation on blood pressure? As we learned in 201 under autonomic dysreflexia.
Drops.
What happened? Okay, right. Extreme head elevation, especially Fowler's or high Fowler's, will decrease blood pressure, which again we don't want to do. Right? We don't want to drop blood pressure. We want to maintain a blood pressure of around 140, 150 systolic. Unfortunately, when we have severe TBI patients, the prognosis again is poor. So just in case, we want to make sure that the patient may be a potential organ donor. So just make sure your nursing supervisor is aware of that. That way, if we do lose the patient, we ask the family, and if they're amenable, or if the patient is already a known organ donor based on their driver's license, then we can't waste these organs. All right, so just be ready. We will skip determining brain death because that's a doctor's responsibility, really. We're not doing that. Let's go now to drug therapy, and then we'll end with surgery. So the preferred diuretic use in order to decrease the brain swelling and fluid in the brains, to decrease cerebral edema, is mannitol. The reason is it's an osmotic diuretic, so it works. It's most beneficial because not only does it decrease the edema, but specifically it decreases the edema in the brain. So it's the most useful among all diuretics because remember, we need to maintain enough blood pressure. So if you do Lasix or anything else, you only drop blood pressure, but you do not necessarily drop cerebral edema. So the mannitol is preferred over Lasix. although as stated here, it's only used as an adjunct to mannitol. I highlighted something here on this box, EBP practice box, because they're saying that hypertonic saline may be as effective as mannitol because, you know, between the two, they're both performing osmosis in order to decrease edema. However, always consider also the sodium levels, because what did we, I mean, this will be considered an alternative if the patient, what is a complication that could result here, which we discussed for exam 1, actually around week 1, I think we discussed it. It's a pituitary problem.
Diabetes insipidus.
Cause was head injury or stroke
SIDH.
that affects sodium levels.
Lady.
SIADH, okay. So this patient may develop SIADH. However, if they do develop SIADH, can we use hypertonic saline? Because remember, in SIADH, they already have fluid overload.
Yes.
Okay, so that would be the only contraindication. If at all you you suspect that the patient may be developing SIADH as a complication of head injury, then hypertonic saline would be contraindicated. But otherwise, yeah, they're useful. Here's a nursing responsibility when giving mannitol. You guys are lucky here because you have all the things you need. You have filter needles, you have IV pumps. I remember back when I was starting, I worked for a government hospital. We had none of these. We were pushing mannitol manually because we didn't have IV pumps and we had to give it slow, of course. Try pushing a drug, a really thick drug, manually using a 50 ml syringe, and you'll develop pretty good carpal tunnel. This drug causes precipitation or causes microscopic crystals. So therefore, when you draw it up, it has to be through a filtered needle. We didn't have neuro units, so our stroke patients pretty much were in the same medical ward as everybody else, and we recognize each other, you know, when we go home, or let's say we meet each other at the grocery store after work, and we say, oh, hey, how are you? And then we find out, oh, you pushed mannitol today, I can see. And then, oh, how'd you know? Well, the crystals are stuck in your cuticles, in your nails, and it's very hard to wash off. So that's how usually I find myself getting home and then, oh, I still have these crystals, plus we can't afford, you know, our hospital didn't have gloves for us, so we had to bring our own gloves to work. And you know, sometimes I don't have money for gloves, so I just wash my hands and then push mannitol. We give opioids. This is already part of your intubated patients, because most of these patients which are moderate or severe head injuries are obviously intubated, so they'll be given opioids. Another purpose of this, besides comfort, is really to decrease the metabolic activity of the brain. So you give CNS depressants like this, so it's two purposes. One is to promote comfort, but also to decrease the metabolic activity. Therefore, if you decrease metabolic activity of the brain, you also decrease oxygen consumption, and therefore decreasing ICP as well. Or in some cases, we may have to, the doctors may opt for inducing a coma. That's for really severe cases, wherein we did surgery already and it's still not working. ICP remains high, so we may have to induce coma using phenobarbital. If this patient survives, have you ever gone to Bellevue?
Yes, I had clinical.
Okay, Bellevue, yeah, Bellevue 6th floor. I think that's where they have the TBI floor, and I think it's north, 6 north. I think is their rehab floor. It's amazing what they do on that floor. I mean, the patient comes in, right? Hardly can keep their head open. They're still wearing helmets because they had craniotomies, so they're missing parts of their skull because the doctor had to remove. They perform a craniectomy. They remove a piece of your skull to allow for brain swelling to occur, thereby decreasing ICP. So they come in, admitted there, they can't hold their heads up. They cannot transfer, they cannot feed themselves, they cannot talk, they cannot use their hands. And then 2 weeks later of rehab, it's amazing. These patients get up on their own, transfer, walk, of course with assistance and supervision, but in a matter of 2 weeks. I mean, look at the amazing frequency of rehab that they do. So we have speech there, we have OT, we have PT. It's incredible. Okay, so these patients relearn everything, right? So they go from pretty much being like a newborn baby where they can't talk, can't feed themselves, can't get out, can't even hold their head up, and then 2 weeks later or more, they're almost back to normal.
Yeah, Professor, sorry to interrupt. We were there last semester in Belgium and 6 West, the brain injury unit. There was actually a patient, he was in Rikers Island and he tried to kill himself. So obviously they caught him before, but pretty much he was brain dead or something, and he couldn't breathe. I mean, he couldn't speak. So it was interesting to see him progress. He started speaking and moving his arms and legs.
Yeah, so you know what I'm talking about, right?
Yeah.
Yeah, so it's really amazing how much work they can, how much improvement these guys make in these patients. Like otherwise you would think that, oh, this patient's hopeless, they're going to be a vegetable for life. But no, they relearn everything. Of course, not every outcome is the same, but for most of these patients, yeah, they have unlimited potential. Okay, it's just really a matter of how dedicated the therapist is. Okay, and then also the cooperation of the family that makes sure the patient continues to receive these resources. And these are the lucky ones. These patients that are in there are not only moderate TBI, but some of them are severe. So they're the lucky ones that really survived and made it to that unit. The others didn't. They never made it out of the 48-hour admission. So here, these are part of the, I would say, nice to know. So do not assume anything that they're unable to understand you. Okay, they may not be making eye contact, but always think that they do. Okay, they remember. All right, this is the chart I mentioned earlier. So this will contain the instructions on when to bring the patient back to the hospital or when to call 911. And these are specific. So if the patient gets a headache, which is common, okay, so this is one of the examples. Headache is expected in mild brain injury. When they do, only give Tylenol, nothing stronger, because you don't want to alter the mental status, which we may mistake for a deterioration. Okay, so no sedatives, sleeping pills, or anything that will alter their mental function or mental status. No, definitely no strenuous activity. That's a given. All right, and then when these occur, then you call up the doctor or bring them to the ER. The headache must be severe. So regular headache, that's okay, that's expected. The vomiting, remember there was nausea also expected, right? Earlier, but now this is now persistent nausea or severe nausea or vomiting. Blurred vision is not, we had sensitivity to light, but we never had blurred vision in the expected signs and symptoms. Definitely drainage from anywhere is not normal, that's not expected. The weakness is now increasing. So regular weakness, that's okay, but increasing weakness, that's not expected anymore. Slurred speech is now a complication. Could be stroke. Progressive sleepiness, worsening headache, and there are now pupillary changes. Of course, these are all reported. Any question? And this part here is now about rehab. I'm not testing this anymore, so the patients will have a long road to recovery. But the most important part there was surviving it. So after they survive, our work though is not finished. It's all about bringing them back to their highest level of functioning, and that's where the miracle workers of the rehab team come in and have their work cut out for them. I will end the night with the surgery, so I'll let you, because these are again long-term, so it's not easy to care for these patients at home. The caregiver, this is a 24-hour care, because these patients, it will take time for them to return to full function. So the caregivers will also need a break. Okay, so this is where respite care comes in. Just like also with people taking care of Parkinson's patients, any other chronic condition like dementia, for instance, Alzheimer's. So those are long-term neuro care. So sometimes the patient outlives the caregiver. The caregiver dies first because of fatigue, if they don't receive respite care. I mean, I know for those who have family members like that, who have to care for these people with these chronic conditions, you know what I'm talking about. Okay, let's go to, I'll skip brain tumors because this, brain tumors is here because it causes ICP, but really between a hematoma and a brain tumor, it's really the same. Plus the treatment here, we also discussed under chapter 22, which is surgery, chemo, and radiation therapy. So there's nothing new to learn here. But again, brain tumors are listed here because they cause increased ICP. I'll do surgery, which if you notice, the chapter didn't do surgery under TBI, but they all put them after the brain tumor, because surgery for brain tumor is the same as any other surgical purpose, because it's really, you're opening the skull. So here is craniotomy. So whether the craniotomy is performed to evacuate the hematoma, to relieve pressure in the brain due to increased ICP, or to remove a tumor. So it's the same. Pre and post-op care will be the same. But I want to make sure, particularly here, between, it's about post-op care. Okay, so we start post-op care. Of course, you do neuro checks. Please read this action alert here. And then complications. We mentioned SIADH earlier. So your And we discussed already SIADH, signs and symptoms and management. So I won't repeat that anymore. These two paragraphs here. So it really depends on which part of the brain was the surgical site. So if it's supratentorial, post-op care will be elevate the head of the bed 30 degrees and position them, well, we know this, midline, head must be in a neutral position, midline, no hip or neck flexion, but you can still turn them side to side. Okay, so the head of the bed is elevated here. However, if it's a lower surgery, meaning involving the brainstem, the patient post-op must be positioned flat, or if you need to elevate the head, it should be no more than 10 degrees up. All right, and then you can still position the patient side lying. You can turn them every 2 hours and make sure, because the incision here is lower, okay, it's in the neck area because your target is the brainstem. And this one obviously is above. The surgical incision here is on the skull itself. And okay, the drainage, okay. So and you also have a critical rescue here for the amount of drainage that must be reported. So here, a small or moderate amount of drainage is expected. However, if the drainage is more than the typical expected amount, which is about 30 ml, 30 to 50 every 8 hours, if it's more than that, then that's already bleeding. All right, and then of course, you have to think about the drainage here, because the drainage device we're using is either Hemovac or Jackson Pratt. And if it's more than that, then that means could there be more that is not drained, which therefore will cause an increase in ICP. Does that make sense? So therefore, it should be reported right away. And that should be it for today. Oh, one more thing. And this is for every craniotomy patient, okay, whether it's supra or infratentorial, these are the routine drugs given post-op or even before surgery, because every patient who has increased ICP will be put on, Miss Esther, what anti-epileptic drug was given for those patients you saw in 6 West?
A lot of them were giving Keppra. We were giving a lot of Keppra.
Okay, what's the generic for Keppra?
Levels of that. I can never.
Yeah.
My brother takes that because he gets he's epileptic.
All right, so actually it's not that they have epilepsy. It was because of the head injury.
No, I know that. Yeah, no, we were taught that by the nurse, but it was a lot. But I was able to identify the medication because it was Keppra. But I just don't know how to pronounce the levels, whatever.
Levetiracetam, right?
Yeah, levetiracetam. It's like really hard to pronounce.
So these are the routine medications. So for every head injury patient who have increased ICP, especially after surgery, and in fact, we actually start giving them before surgery, but especially after surgery. So we put them on the standard Keppra, which is your anti-epileptic drug, and then we put them on either famotidine or pantoprazole, so either a H2 receptor blocker or PPI. And the steroid here is always only dexamethasone. There are no other forms of steroid use for increased ICP patients. It has to be Decadron only. So this applies for anyone, okay, whether the patient has a brain tumor, a stroke, or head injury, we only use dexamethasone. So that would be for reducing cerebral edema, therefore decreasing ICP, and for the headache, we use the routine Tylenol. And antibiotics are given before and then after surgery. This is, of course, prophylactic antibiotics. This is not because they have an infection, okay? And that is definitely it. Any questions?
No,
Oh
just
no, sorry. I keep saying no, and then I keep finding new things. Okay, this is definitely the last one. Okay. This is about monitoring the ICP, because we kept saying ICP, then we never talked about how do we get the number. All right, so the patient will have a ventriculostomy. There are other ways. We have the intracranial bolt, we have the epidural screw, but then the most effective way is the IVC. So this is an intraventricular catheter. This is inserted via a ventriculostomy. So we'll drill a hole in the skull. There's a marker. I don't really know how they identify it. They just do some reference as from the patient's eye to the ear. I can never remember how they pinpoint the position, but there's a way to find the right spot to drill the hole. So of course they'll clip the hair and then drill the hole and then insert the catheter. The problem with IVCs or with any other ICP monitoring device is it's invasive. Plus the skull, although we clip the hair is going to grow. So it's really hard to keep it clean. So, I mean, we do put a bacitration around the insertion site every day, and then we do, dressing at least twice a day. But that's your frequent problem, is this may cause an infection because you can't really keep the area clean, unlike other areas where it's on your arm, for instance, or any other part of the body, because the skull, even though, again, we clip the hair grows back, so which makes wound care very difficult. Anyway, the IVC will give you the reading. So the catheter has a pressure monitor, and which, of course, this will be connected to a transducer. So the catheter serves two purposes here, which is what makes the IVC very useful. Is not only do you monitor ICP, but you could also drain CSF using the same catheter, right? So not only can you monitor the level, the pressure, you can also decrease ICP by draining CSF. That makes sense?
yes.
Okay. All right, that's it. Finally.
I have a question, Professor. The quiz next week is on this chapter, and the other one we did on the interleukins and all of that, right?
Yeah, chapter 17, the transplant things, signs and symptoms, and then management, the 3 types of rejection, and then, of course, chapter 45, but only the TBI part.
Okay.
So next week, we'll begin with Glasgow Coma score, scoring in practice, and then stroke. We'll finish stroke next week. And then that's 6, and then we'll have our exam 2 on week 7.
All right.
Easiest test you've ever taken.
Professor, Professor, I have a question about the last week class. So in the acute rejection in chapter 17, it says it occurs within 1 week to 3 months. But then on the kidney rejection table in chapter 68, it says acute rejection happens a week to any time after surgery. So what is the time frame?
No, 17, it said 1 week to a few months, right? And then sporadically throughout. Remember?
Okay.
So there's really no time limit as to when it will occur. I mean, it could occur for the rest of the patient's life, or as long as the graft's life.
I see, I see. And
Because yeah,
yes.
the it's different.
Yeah. So,
Whereas chronic
go.
wasn't caused by the cytotoxic activity. It was more for chronic inflammation and scarring.
Mhm.
You remember?
Yes.
Yeah, so that's why the intervention, which is drug management, can't really stop it, because it's not technically the action of the T lymphocytes. It's more of
Inflammation.
general inflammation, yeah, in response to having a foreign body lodged inside the patient.
Yes. Thank you, Professor.
Is that? Yeah, okay. Anything else? All right, if anything comes up, text me or send an email. And
Thank you.
enjoy your